So, I would like to invite Dr. Sivakumar from Ranipet presenting Candidacy for Bariatric Surgery, Patient Selection and Precision Decision Making.
So, very good evening to everyone. I am the last batsman standing in front of the day. You could have been tired of hearing the lectures from the morning. So, I am the odd man out who is standing in front of the ENT forum. I first like to congratulate Dr. Shankar and his team for organizing such a wonderful conference. In the meantime, I like to extend my thanks for inviting a bariatric surgeon in the ENT and sleep apnea consultant forum. So most of you will be seeing patients of OSA in your OPDs, but you will have a confusion whether you can treat the patient first or you can send the patient to a bariatric surgery, that is a bariatric surgeon, because obesity is one of the major risk factors associated with the OSA. So today I am just going to talk about what is the link between the obesity and that is OSA, and what is the pathophysiology linking it, how to approach, what the international guidelines says, who is the right candidate for bariatric surgery, when to refer the patient for a bariatric surgeon, when to take up the patient for a sleep surgery as a first line treatment. So OSA and obesity is a global pandemic. So as all of us will know, approximately nearly 1 billion patients worldwide are affected with OSA. So nearly 70% of the severely obese patients are found to have either moderate to severe OSA. I can say that every 10% increase in the body weight increases the risk of OSA by nearly 6-fold. Since OSA has been associated with most of the diseases affecting from head to foot, from affecting various systems. So coming to the pathophysiology, why does obesity causes OSA? Basically what happens in obesity, there is an increased deposition of the fat all over the body, mainly increased deposition of fat around the neck tissues, especially over the pharyngeal tissues. There is an enlarged tongue happens. Because of that, there is a decrease in the retroglossal space. Because of the decrease in the retroglossal space, there is a narrowing of the upper airway. In addition to the negative intrathoracic pressure during inspiration causes collapse of the upper airway. Because of the collapse, there will be increased hypoxemia. This leads to increased metabolic dysfunction. Because of the metabolic dysfunction, what happens? Again, the weight gain is keep on increasing. So as told by the previous speaker, it has a bidirectional relationship, not only with the obesity, has not only with the obesity alone, with various metabolic efforts. So OSA in turn aggravates the obesity, obesity in turn aggravates the OSA. So as I told already, it is a systematic trap where that is the intermittent desaturations can lead to low-grade inflammation with increased catecholamine. Because of that, it will worsen the underlying metabolic syndrome, which again increases the weight gain. Because of the weight gain, again what happens, there is a neck muscle fat is getting increased, the airway collapse is going to happen. So there is another new pathophysiology we have to concentrate on this, because the recent literature from the sleep medicine has quoted that weight loss is uniquely effective in OSA management. How? Because the past theory they used to tell about the neck pressure theory, that has been changed to targeted fat reduction therapies, because mainly the enlarged tongue and enlarged fat around the pharyngeal airway is the primary culprit going to worsen the OSA, worsen the obesity. So after the bariatric surgery, what happens? There is a targeted fat reductions happens around the airway area. Because of the reduction in the fat around the airway area, there is an increase in the diameter of the airway, which increase and improves the overall quality as well as duration of the sleep. And another thing is in obesity, what happened? Especially because of the abdominal wall obesity, that will push up the diaphragm. Once the diaphragm has been pushed up, obviously the lung volume is going to get decreased. Because of the decrease in lung volume, other metabolic events are going to happen. But post bariatric surgery, what happens? So because of the weight loss, there is abdominal obesity going to get decreased. So diaphragm has been pushed in a normal position. So obviously it increases the lung volume, it increases the functional residual capacity. So and also it keeps the trachea in position. That is, the tracheal traction is being maintained. Because of the maintaining of the tracheal traction and airway, obviously the sleep is going to be increased. The quality of sleep and quantity of sleep is going to be increased. And there has a shift is happened in the precision medicine obesity phenotype. Usually, as Dr. Vedras has quoted about this, BMI alone is not an imperfect, it's an imperfect predictor of OSA risk, because There's an entity called metabolically abnormal normal weight people. In those patients, actually the BMI will be normal, but they are the worst candidate where the risk of OAC is found to be very high. So the recent guidelines have shown that any patient with OSA, they has to be screened based on the metabolic health panel rather than the BMI alone. We should not wait for the patient to attain a specific BMI. Okay, so if the patient is having metabolic abnormality, they have to be screened carefully for OSA. What bariatric surgery does? Actually, it interrupts the cycle, whatever the bidirectional relationship has, it is being interrupted by the bariatric surgery. So all the cycle has been reversed, so that improves the OSA as well as the weight loss. So I don't want to talk about the clinical evaluation, which has been already could have been heard from the morning. The thing I want to emphasize here is any patient with obesity who has been evaluated for OSA, three things we have to think care of: the BMI, what is the neck circumference, what is the weight circumference. So various screening tools are available. The most commonly used tool is the stop bank score. You could have heard from the morning, but here I want to emphasize that obviously 0 to 2 is a low risk. Even though the stop bank score is 2, if the patient is a male gender, BMI is more than 35, and the neck circumference is more than 40, that is more than 41 in female or more than 43 in male, even though the stop bank score is 2, they belong to the high risk group. They have to be treated aggressively. These are the other certain screening tools I don't want to discuss in detail. And one of the gold standard for diagnosing OSA, that is the diagnosing AHI, is the sleep study, that is a polysomnography. So the normal value is less than 5. If it is 5 to 14.9, it is a mild. 15 to 30, it's a normal. More than 30 is called severe. Any patient who is an obese patient or is an OSA patient, the evaluation should include a multidisciplinary team approach, which includes a bariatric surgeon, a pulmonologist, anesthesiologist, physician cum endocrinologist and cardiologist, ENT and sleep apnea consultant, dietitian and psychologist. Because the successful outcome of any surgical procedure depends not only on surgery alone, it depends upon the comprehensive multidisciplinary team care. Is OSA alone is an indication for bariatric surgery? No. So who is the right and appropriate candidate for bariatric surgery? Any patient with moderate to severe OSA is an ideal candidate for bariatric surgery. If the patient is on CPAP therapy but he is intolerant and the BMI fits into the criteria for bariatric surgery, that the BMI criteria fits, then he is an ideal candidate for bariatric surgery. OSA patient with that is obesity hyperventilation syndrome, who is having increased daytime somnolence, in addition underlying metabolic illness like uncontrolled or poorly controlled diabetes, hypertension, dyslipidemia, worsened GERD, especially HILS grade 4 or grade 3 GERD may have worsening OSA symptom also, and underlying severe fatty liver disease. What international guidelines says? This is the latest guidelines, ASMBS and IFSO guidelines 2022. Till 2022, we have used other guidelines called NIH criteria. According to that criteria, any patients with BMI of more than 40 is ideal candidate for bariatric surgery. This is as per the 1991 NIH criteria. The patient BMI of more than 35 with underlying comorbid illness, then they are ideal candidate for bariatric surgery. But the recent guidelines, that is the IFSO 2022 guidelines, has reduced the threshold for bariatric surgery. Any patient with a BMI of more than 35, irrespective of the underlying metabolic illness, they are the ideal candidate for bariatric surgery. The BMI between 30 to 34.9 is with underlying metabolic disorders, they are the ideal candidate for bariatric surgery. So but in considering the Asian population, because of the variation in the fat distribution, this threshold has been reduced to 27.5 with underlying medical illness. They are the ideal candidate for bariatric surgery. So appropriate patient selection is the single most important factor that determines the successful long-term outcomes. So most important thing is pre-op optimization of the patient. The goals before surgery is you have to improve the oxygenation. So if the patient is an ideal candidate for CPAP therapy, that has to be started, and the patient has to be adhered to the CPAP therapy. Minimum 4 hours of CPAP therapy at bedtime has to be instituted. The patient already on CPAP therapy, other patient we have to tell the patient to bring the CPAP machine. That patient has to be hospitalized at least 2 to 3 days before proceeding for bariatric surgery. They have to optimize, and post-operatively they have to be continuing on CPAP therapy. And we have to reduce the risk factors which tend to worsen the post-operative. Mainly the smoking that has to be stopped minimum 4 weeks before surgery. We have to optimize the comorbidities like diabetes, hypertension, dyslipidemia, and most important thing is pre-op weight loss. We have to encourage the patient to lose at least 5 to 10% of the weight loss. How it helps? Because of the, usually I put my patients on liquid diet, that's very low calorie liquid diet for minimum 2 weeks before posting the patient for surgery. This will help us to assess whether the patients mentally they are stable to undergo the procedure. Okay. Second thing is it will cause shrinkage of the liver. Because of the shrinkage of the liver, intraoperatively as a surgeon I know how difficult if the liver is enlarged. So because of shrinkage of the liver, that makes to do the procedure easily. And third thing is it helps in the anesthetist point of view also. Because of the 5 to 10% of weight loss in the pre-operative period, actually the neck fat also tend to be decreased. So the airway little bit, the difficulties tend to be decreased if they lose 5 to 10% of weight loss pre-operatively. Of course, untreated OSA has a significant risk perioperatively because it increases the risk of airway obstruction, hypoxemia, reintubation, and cardiovascular events. ICU admissions are tend to be high. And as already said by Dr. Dinakaran anesthetist, they are more sensitive to OPR. So make sure we use non-OPR, that is OPR sparing multimodal anesthesia for patients postoperatively. There are various bariatric surgical procedures are available. I am not going to discuss in detail about the surgical steps or surgical procedure. The most commonly done procedures are sleeve gastrectomy, Roux-en-Y gastric bypass, and one anastomosis gastric bypass or mini gastric bypass. Among those procedures, sleeve gastrectomy is the most commonly performed procedure because it's a very simple procedure, easy to do, and complication rates actually high, but it's easy to manage. But in relation to the OSA, if very good done sleeve along the period of time after 6 months to I can say up to 5 years studies are available, there is a 60 to 70% remissions of OSA happen with very good sleeve. And coming to ROIGB, it has a very good metabolic effect because sleeve gastrectomy is a restrictive procedure, whereas ROIGB is a restrictive as well as malabsorptive procedure. So the sustained weight loss is going to happen. Because of the long-term sustained weight loss, symptom control is much better compared to sleeve gastrectomy. Nearly 70 to 80% of OSA remissions is going to happen with very good done ROIGB. So another commonly done procedure is an OAGB. Comparing the three procedures, the OAGB has a maximum OSA remission rate nearly 80 to 90%, and technically speaking, when compared to ROAGB, the OAGB is technically a single anastomotic procedure. It is easy for the surgeon to perform, but the problem with this again is a single anastomosis. The chronic bile reflux is going to happen in 3 to 4% of patients. If it persists, it might increase the risk of OSA also. So how bariatric surgery improves the mechanics in OSA patients? As I told, after sustained weight loss, the neck circumference is going to get reduced because of decrease in the fat deposition around the neck, essentially around the pharyngeal tissue. The tongue, which is enlarged, is going to getting reduced, okay, and visceral fat is getting reduced. So because of that, abdominal obesity is getting reduced. So obviously the lung volume is going to increase. Because of the increased lung volume, functional residual capacity is going to be increased. Obviously the systemic inflammation is getting reduced. Because of all these features, in this study you can able to see at the end of 6 months, almost 4.5 to 5 centimeter increase in the diameter of airway at multiple level can able to see. Because of that increase in the diameter of the airway, the patient's quality of sleep and duration of sleep is going to be increased. So obviously daytime symptoms are going to be getting decreased. So that overall there is an improvement in the OSA symptom. So what does the current evidence say? Does bariatric surgery improve OSA? Yes, obviously multiple metabolic meta-analysis and systematic reviews have shown that there is a significant reduction in the AHI by nearly 50 to 60%. It improves oxygenation, it reduces the daytime sleepiness. Overall, it increases the quality of sleep. Almost nearly 40 to 60% of the patients tend to discontinue CPAP therapy subsequently. So it decreases the CPAP dependence. So the weight loss remains the most effective long-term treatment for obesity-related OSA. These are the procedures according to the OSA, which already I told. There are certain newer techniques called SODI, that is a single anastomosis, duodenal ileostomy with sleeve or duodenal stitch procedure, which is not done commonly. Usually it is being done for selective patient who is a supervised, where the BMI is more than 50. There is a highly malabsorptive procedure with the risk of nutritional deficiency very high, but the OSA remission rate is found to be nearly 90% in these procedures. These are certain landmark studies comparing the obesity with OSA, which concluded that bariatric surgery should be viewed as a metabolic treatment with profound benefits for sleep disorder breathing. Although even after the subsequent amount of weight loss, there are certain factors tend to cause either persistent OSA or recurrent of OSA, especially the age is more than 50, male gender, severe pre-op AHI, long-standing obesity or inadequate or incomplete weight loss or weight regain. So the resolution of obesity doesn't always equals the resolution of OSA. So always long-term follow-up is mandatory. We have to follow the patient for 6 months to 12 months. We have to redo the sleep study and assess how the symptomatology is. Accordingly, we have to decide about either discontinuing or continuing CPAP therapy. So we have to monitor the weight regain, OSA recurrence, nutritional and vitamin deficiencies and mental health of the patient. And there is a major paradigm shift is happening in the treatment of obesity as well as OSA. This has been quoted by Dr. Vettil also previous slide. There is a recent trial, that's a Sarmont OSA phase 3 trial which is recently concluded. It is a 52-week landmark trial where the newer drug tirzepatide, this is a GLP-1 GIP analog, which is shown to demonstrate 60% reduction in that is AHI, and moderately to severe OSA patient and BMI more than 30 patient. So this can be used as a primary adjunctive or alternative to CPAP therapy if the patient is intolerant. So the current standard of care is rapidly shifting from the mechanical therapy to combined therapy, the CPAP therapy along with tirzepatide. If you say immediately if you are seeing a patient, if you convince the patient for surgery, most of the patient may not accept. In those kind of patient, even as a bridging therapy, you can use this drug. I am using for my patient who is delaying surgery. It has a very good results. Over the period of 1 hour, I can say nearly they lose 12 to 15 kg of weight among total body weight. So these are certain frequently asked questions among the people. Is OSA is an indication for bariatric surgery? Yes, if the criteria for BMA has been built, they are the ideal candidate for bariatric surgery. Does it cure OSA? Actually, it won't cure OSA. It won't guarantee complete resolution, but it improves the symptoms by 60 to 70%. Can CPAP be discontinued immediately? We can't immediately, but down the lane, maybe after the 6 to 12 months, we have to assess. We to do the sleep study. If the improvement in the symptoms are there, then we can discontinue. We can discontinue CPAP therapy. So, as a ENT surgeons, you want to know when to refer a patient, when to go ahead with sleep surgery as a first time. If the patient BMI is less than 35 or less than 40 without underlying metabolic illness, safely that patient can be taken up for sleep surgery pathway. If the BMI is 30, more than 35 or more than 30 with underlying metabolic illness, the patient has to be subjected to bariatric surgery first. Because without treating the systemic disease, if you are treating the local disease, obviously it will recur, it will persist. This surgery can be done as a staged manner also. As a phase 1, subject the patient to bariatric metabolic surgery. Once the significant amount of weight loss has been already happened, then if AHA rebound, that means local pathology is that, then as a staged procedure, second procedure, we can subject the patient for sleep surgery pathway. So bariatric surgery, sleep surgery are not mutually exclusive competitors. So my key take-home messages are: obesity is the major modified risk factor for OSA. Bariatric surgery is an effective treatment for appropriately selected candidates if the criteria has been met. Careful patient selection and multidisciplinary plan management improves the outcome. Perioperative optimization enhances the safety postoperatively. Long-term follow-up is essential because residual OSA may persist. To conclude my talk, OSA should not be viewed as an isolated airway disorder. Bariatric surgery should be considered as part of a comprehensive OSA management in eligible patients with obesity. Appropriate patient selection according to the international guidelines is very crucial. The bariatric metabolic surgery offers substantial improvement in AHI, cardiometabolic health and overall quality of life. So patients require lifelong follow-up to monitor the weight, nutritional status and sleep health. So I like to end my talk with the quote: treat the disease of obesity, not just the symptom of airway obstruction. Thank you.
Thank you, Doctor. So I request the chairpersons to join the stage. I request Dr. Saad Ahmed, Dr. Ganesh Raja, Dr. Dinakaran and Dr. Vettive to join the stage to receive their mementos. I would like to invite Professor Gauri Shankar from Chennai to the stage. So now I request chairpersons to come to the stage. I request Dr. Sanu Moideen and Dr. Shankara Subramanian to join the stage to receive their mementos. Thank you. I request Dr. Sanu Moideen to honor the chief guest. Thank you all. For the next 3 lectures, I invite Dr. S.K. Ravichandran, Dr. Kalidas, and Professor Gandhi.
You like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them
We
how
have
it
come to the end of the
feels.
day. Tomorrow, the first session is live. Thank you all for your immense presence. Makes